Hello friends, today I am going to discuss about pregnancy and breast cancer, Green Top Guideline number 12. Now the summary is breast cancer is the most common cancer in females with a lifetime risk of 1 in 9 in the UK and is the leading cause of death in women aged 35 to 54 years. The prognosis of breast cancer is improving with 5-year survival around 80% for the under 50s age group. However, the survival rate may be lower in very young women. Fewer than 10% of women diagnosed with breast cancer subsequently become pregnant, but increasing numbers of women are seeking pregnancy following treatment. Young women presenting with breast cancer often have fertility related concerns and need well informed discussions on fertility, pregnancy, and lactation after breast cancer and the availability of fertility preservation procedures. What is the optimal management of breast cancer diagnosed during pregnancy? Pregnancy itself does not appear to worsen the prognosis for women diagnosed in pregnancy compared with non-pregnant controls matched for age and stage, provided that standard treatment guidelines for the breast cancers are adherent to. However, as pregnancy associated breast cancer occurs in a young population who may have features that carry a higher risk of metastasis, such as high grade tumors and estrogen receptor negative tumors, these young women may be expected to have an inferior prognosis. Diagnosis: women presenting with breast lump during pregnancy should be referred to a breast specialist team, and any imaging or further tests should be conducted in conjunction with the multidisciplinary team. Tissue diagnosis is with ultrasound guided biopsy for histology rather than cytology, as proliferative change during pregnancy renders cytology inconclusive in many women. Histology is similar to that in age-matched non-pregnant counterparts. Bone scanning and pelvic X-ray computed tomography are not recommended because of the possible effect of irradiation on the fetus. If there is concern about bone involvement, a plain film of the relevant area and or magnetic resonance imaging to minimize radiation exposure to the fetus is suggested. Consideration of termination of pregnancy. The decision to continue the pregnancy should be based on careful discussion of the cancer prognosis, treatment, and future fertility with the woman and her partner and the multidisciplinary team. Treatment during pregnancy. The multidisciplinary team review outcome should be forwarded to the obstetric team and family doctor. Surgical treatment including locoregional clearance can be undertaken in all trimesters. Reconstruction should be delayed to avoid prolonged anesthesia and allow optimal symmetrization of the breasts after delivery. Sentinel node assessment using radioisotope scintigraphy does not cause significant uterine radiation, but blue dye is not recommended as the effect upon the fetus is unknown. Radiotherapy is contraindicated until delivery unless it is life-saving or to preserve organ function. Example: spinal cord compression. Systematic chemotherapy is contraindicated in first trimester because of a high rate of fetal abnormality, but is safe from the second trimester and should be offered according to protocols defined by the risk of breast cancer, relapse, and mortality. Tamoxifen and trastuzumab are contraindicated in pregnancy and should not be used. Timing of delivery of the baby. The birth of the baby should be timed after discussion with the woman and the multidisciplinary team. If early delivery of the baby is necessary, consideration of corticosteroids for fetal lung maturation is appropriate. However, birth should be more than 2 to 3 weeks after the last chemotherapy session to allow maternal bone marrow recovery and to minimize problems with the neutropenia. Lactation. Women should not breastfeed when taking trastuzumab, Herceptin, Roche, or tamoxifen, as it is unknown whether these drugs are transmitted in breast milk. Breastfeeding while on chemotherapy is not advised, as the drugs cross into breast milk and may cause neonatal leukopenia with a risk of infection. There should be a time interval of 14 days or more from the last chemotherapy session to start off breastfeeding to allow drug clearance from breast milk. What are the contraceptive choices for women wishing to avoid pregnancy after treatment of breast cancer? Non-hormonal contraceptive methods are recommended. Although hormonal contraception may be considered after at least 5 years free of recurrence, World Health Organization and UK Category 3. What advice should be given to women planning pregnancy following breast cancer? Women planning a pregnancy after treatment for breast cancer should consult their clinical oncologist, breast surgeon, and obstetrician. Women on tamoxifen are advised to stop this treatment 3 months before trying to conceive because of the long half-life of the drug, and to have any routine imaging before trying to conceive to avoid the need for imaging during pregnancy. Impact of pregnancy on risk of recurrence. Women can be reassured that long-term survival after breast cancer is not adversely affected by pregnancy. Time interval before pregnancy. Advice on postponement of pregnancy should be individualized and based on treatment needs and prognosis over time. Most women should wait at least 2 years after treatment, which is when the risk of cancer recurrence is highest. Outcome of pregnancy. The majority of pregnancies after breast cancer proceed to live birth. Women can be reassured concerning the risk of malformation in children conceived after treatment for breast cancer. What is the optimal management of pregnancy following treatment for breast cancer? Pregnancy following breast cancer should be jointly supervised by the obstetrician, oncologist, and breast surgeon. Echocardiography should be performed during pregnancy in women at risk to detect cardiomyopathy through resting left ventricular ejection fraction or echocardiographic fractional shortening. What advice should be given to women wishing to breastfeed following treatment for breast cancer? Women can be reassured that they can breastfeed from the unaffected breast. What is the effect of breast cancer treatment on the woman's fertility? The effect of treatment on fertility should be discussed with all women of reproductive age diagnosed with breast cancer, and written information should be provided. Referral to a fertility specialist should be available. Specialist counseling should be available. A recent joint working party of the Royal Colleges of Physicians, Radiologists, and Obstetricians and Gynecologists in the UK recommended that people with cancer should be fully informed of potential gonadotoxicity before treatment, and specialist psychological support and counseling should be available. What is the effect of adjuvant chemotherapy on fertility? Chemotherapy-induced gonadotoxicity may cause permanent amenorrhea with complete loss of germ cells, transient amenorrhea, menstrual irregularity, and subfertility. The degree of gonadotoxicity is dependent on the specific agent used, the cumulative dose administered, and the woman's age. Alkylating agents such as cyclophosphamide have well recognized gonadotoxicity, and the classic CMF regime which include cyclophosphamide, methotrexate, 5-fluorouracil, causes a higher incidence of amenorrhea than anthracycline-based regimes such as FEC, which is 5-fluorouracil, epirubicin, and cyclophosphamide. The newer taxanes appear to be less gonadotoxic. What is the effect of adjuvant hormonal therapy on fertility? The agents used for adjuvant hormonal therapy do not in themselves cause long-term effects on fertility. Tamoxifen, a selective estrogen receptor modulator, often causes menstrual irregularity and there is an increased risk of endometrial pathology. Conception during tamoxifen therapy should be avoided because of potential teratogenicity, and a washout period of 2 to 3 months is advised. Gonadotropin releasing hormone analogs cause amenorrhea and profound estrogen deficiency. Women may find the menopausal symptoms worrying, but the effect is entirely reversible. Trastuzumab is a monoclonal antibody that binds selectively to the HER2 protein expressed by some breast cancers. There is no evidence that it impairs fertility, but pregnancy is not advised during treatment. What advice should be given to the woman about postponement of pregnancy before embarking on further pregnancy? Women are generally advised to postpone pregnancy for at least 2 years after treatment and may be advised to continue tamoxifen for 5 years. However, age is a major determinant of fertility and delay with already poor ovarian function owing to chemotherapy is likely to lead to infertility. Women in their 30s desiring pregnancy may wish to discuss the value of prolonged treatment with tamoxifen and consider discontinuation after 2 to 3 years. Resuming treatment with tamoxifen after childbearing has not been studied, but it is a reasonable strategy. Can fertility be preserved before treatment? GnRH analogs. There are insufficient level 1 data to support the routine use of GnRH analogs for ovarian protection in estrogen receptor positive breast cancer. Cryopreservation. Ovarian stimulation for egg or embryo freezing requires careful discussion in light of unknown long-term risks. Modified stimulation regimes should be considered for women with estrogen-sensitive breast cancer. There are insufficient data to support ovarian tissue storage for fertility preservation in women with breast cancer. This should be offered only in context of a research trial. Every breast oncology service should have a designated pathway for prompt referral to a fertility specialist able to offer assisted conception. Service provision should not be dependent on local in vitro fertilization funding arrangements. Assisted reproduction after treatment for breast cancer. Fertility treatment after chemotherapy is limited by loss of ovarian reserve. The stimulation aspect of in vitro fertilization carries a theoretical risk as it is a hyperestrogenic state, although of shorter duration than pregnancy. Women who have chemotherapy-induced menopause can become pregnant with donated eggs. This requires short-term hormone replacement therapy, which again carries a theoretical risk. Replacement of cryopreserved embryos is also performed in a medicated hormone replacement therapy cycle. Women for whom pregnancy is contraindicated may wish to consider surrogacy. Thanks for watching. If you like my video, please subscribe to my channel and click the bell icon for more updates.